Okay, hi class. I am so glad we're doing this online stuff. I'm hoping that I can do this video and it will work out. Um, so let me know if there's any issues with the uploading. I'm hoping it does upload. But today we're going to talk a little bit about our presentation for the mock oral exam. And I'm going to post up some stuff for you guys that hopefully you're looking at as you watch the video. But let's talk about what this entire assignment is going to cover. So I'm going to post the overview of the questions. So the way this is going to look is today, being Sunday/Monday, I am going to send everybody their vignette. So this is your client. What I want you to imagine is that, um, you know, for those of you who will be taking the oral exam, you will choose a client from your practicum that you've been working with. So this is kind of mirroring that whole idea. I'm going to give you your vignette, which is your client, that you're going to go through the rest of the quarter with. Then the week before the actual exam, I'm going to give you another vignette that will be your other client. So you'll be doing a presentation, then you'll be doing a vignette portion. Okay, so for the presentation portion, you're going to come with your flashcards all ready to go, answering every one of the questions. For the vignette portion, you are going to answer the 10 questions that are asked in this exam by one of your fellow student examiners. We will talk about this more in person so that it makes sense. I don't want you guys to sit through and be confused about this right now. So the 10 questions are: what are the legal issues presented in this vignette and how would you address them? What are the ethical dilemmas presented in this vignette and how would you manage them? How would you manage potential crises issues in this vignette? What is your diagnostic impression of the clients in this vignette using the DSM-5? And then the theory questions are: how might your chosen theory explain what is going on in this vignette and how would it assess the clients or the system? What is your treatment plan, including short-term and long-term goals? So you should have 2 to 3 short-term, 2 to 3 long-term goals. I do not want beginning, middle, and end phase. 2 to 3 short-term, 2 to 3 long-term goals. And what intervention might you use to handle? And the examiner is going to pick one of your short-term goals. And then what intervention might you use to handle one of your long-term goals? And what if these interventions don't work? So essentially thinking of this, you are going to try to manage anxiety. So your intervention is to teach them deep breathing. And this kid says to you, I don't like breathing, which is something I've gotten quite a bit. So they say, I'm not going to breathe. Then what are you going to do if they're not willing to do that? Or I'm going to work on this trauma by art, by having them draw. I want to do an introduction using house tree person. And they say, I won't do art. Then you have to have something else you're going to do. Briefly describe how you would handle this from a different theoretical perspective. So you're going to choose your main theory that you're going to do your treatment plan and your intervention and your goals and everything else on. One theory, I do not want it to be eclectic. I do not want it a little bit of this, a little bit of that. A pure and true theory, so CBT, any of the systems theories, any theory that you feel you can use with your client. Then a second theory. You don't need to do a treatment plan, just what else would you do if this didn't work? So I, for example, had a client that I thought, I'm going to do attachment theory with this client. And he just wasn't quite ready to go that deep. So I had to pump the brakes and figure out what's something to get his feet in the door. And the thing to get his feet in the door of therapy was structural therapy. So then I was able to do attachment theory after we were able to do some structural theory. Your human diversity question: how does your understanding of culture inform your conceptualization, goals, and interventions? Alliance: describe your therapeutic alliance and possible biases or countertransference in this vignette, and how would you handle them? And the final question: how would you monitor the client's progress in therapy? What I don't want you to be doing right now is thinking too far ahead. I'm also going to post this little grid, which is going to show the order of operations, the order of this exam. So we're going to learn it in a different order than we are going to present it. So when you present it, you will start with law, ethics, then crisis, your clinical evaluation, which includes your diagnosis, theory, treatment plan, diversity, alliance, outcome. But I'm going to teach it to you in a different way because it makes sense to teach it this way. Remember through all of this that there is going to be a golden thread. So this should start from the top of your client. So from their presentation of their symptoms, this little thread goes down from presentation of symptoms down to the diagnosis, down to your goals and treatment plan, to your interventions, and to your outcome. Which means that if you are seeing somebody who presents with irritability, isolation, maybe some self-harm, and you've diagnosed them with depression, then your goals and treatment plan should be covering depression and the symptoms thereof, which means your outcomes should be linked to depression and the symptoms thereof. So if I'm working on depression with this client, I should not then be treating, I don't know, I shouldn't be then treating anxiety, I guess. Now, if I'm going to diagnose them with anxiety and depression, if I'm treating depression, I shouldn't be treating borderline personality disorder or antisocial personality disorder or OCD. I should really be focusing on this. So today we're talking about clinical evaluation and diagnosing, I really want you to remember that you're not throwing the book at any of your clients. We handle our clients. This is us mirroring our work in the field, and we handle our clients with love. So with love, we don't need to diagnose every client with 15 diagnoses, even if they have symptoms of some that might fit. So you're going to kind of remember Occam's razor in this, that whatever makes the most sense, go with that. So anything you're going to diagnose, remember now, you're going to treat it later on. So what we're going to be doing in the clinical evaluation is considering all parts of the client, their age, their gender, what they look like in the room, their symptoms, the presenting issues, so who's referring them and why, and then our diagnosis. And when it comes to our diagnosis, this is not the time to rule out any, I don't want to see rule outs in there at all. In fact, I will mark you down if I see rule out in there at all. If you are not sure between a diagnosis, it's fine. It's fine to say, I'm not quite sure today what they are. And then maybe a couple weeks down the road as we continue, you're like, of course, it's depression. It's okay to put a provisional diagnosis down, but I do not want to see you ruling anything out. So you do not need to know ICD-10 codes or the DSM-5 codes. I don't need those code numbers. So when you're presenting, I don't want to hear F31.1. I just want to hear anxiety disorder and then whatever else is specified with that. You do need to explain why you are diagnosing. So what you're going to be turning in to me should be pretty much a type up of what you would say to me. So I am diagnosing Dana with anxiety because she presents with, ruminating thoughts, difficulty sleeping, yada, 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 yada. So it's going to feel very, very, very redundant, and it is. And that's just kind of what it's going to be. You do need to provide a diagnosis for anybody in a family vignette. None of you will have a family vignette, I don't think. So you will just need to diagnose the main client, which is going to be the kiddo. Choosing your theory. So let's say you choose a theory that does not pathologize. Like some of you might choose narrative theory, which doesn't really pathologize, meaning it doesn't diagnose. You should say, narrative theory does not necessarily diagnose, but for the purposes of this vignette, I am going to diagnose them with this. If you're going to diagnose them with something within a theory, like something with attachment theory, this person seems to have an insecure attachment, that's fine, but that's not a DSM code. So insurance is going to say, what? So still diagnose them with a DSM-5 diagnosis. This is where you're going to want to remember your unspecified or your otherwise specified diagnoses. So they might meet all but one criteria of anxiety, and you'll say, well, but it's anxiety. It's pretty close. Then it's anxiety, unspecified. In this I'm asking you for your diagnosis and know that there are possibilities of multiple diagnoses. So this is why we're going to be going through this where I might look at it and then a classmate is going to look at it as well to kind of give some perspectives in that multiple people could be looking at the same client and deciding that it's a very different presenting problem and a very different diagnosis that comes with that. And that's okay. So in what I've seen in many of the vignettes, you'll see a lot of mood disorders, anxiety disorders, some trauma disorders, possibly bipolar, definitely neurodevelopmental disorders like autism and ADHD. There's some that might have a feeding or elimination disorder, definitely ODD, possibly conduct disorders. So just gonna look out for that. And don't sleep on your Z codes. So go into the back of the DSM-5 before you diagnose your client and figure out what some of these diagnoses are because they are fantastic. Now, insurance in the world is not going to reimburse for a Z code, but some of you had this be the case in your child interviews last quarter where you said they're pretty much a good kid. This seems to be more of a family problem, or I don't feel very comfortable diagnosing this kid. And what I'm going to say to that is I completely understand and respect that, but we still have to diagnose something if we're going to work with somebody. It's just best practice. And just because we don't want to diagnose little Timmy with depression or anxiety because we understand that it's mostly a product of their family and their parents, and it's really their parents' issue than their own, it doesn't mean that they don't have the disorder. And that is what we are treating, so it's what we should be diagnosing. So also check out your Z codes. We've got some really great ones in there like parent-child relational problem, which most kiddos have, right? If they're having any issues with their parents, that's a great one. So check them out. And please, again, remember that if you are going to be diagnosing it, you are going to have some goals and interventions to treat it. Okay, so that's kind of our big thing for this. What I want to do is we're going to practice on this client Juan. And so I'm going to be posting one up as well. He's going to be my client throughout the entire quarter that I am going to be working on with you guys. So I'm going to read it out loud. You guys can read it as I read it. You're an intern at a community counseling center that provides services to local schools. Your supervisor, Dr. Chibo, recently became a board certified psychologist. He supervises you, 4 other interns, and 2 trainees for 1 hour individually and 2 hours for group each week. Juan H10 is your 11th client. Juan's parents, Linda and Jorge Jimenez, came to the initial intake session without Juan. Linda, who is 35, is a housewife and active volunteer, and Jorge, age 37, works as a flight engineer for Taka Airlines, serving South and Central America out of San Francisco. Jorge is quiet through most of the interview except for saying he is traveling 3 to 4 days a week due to work and he knows his son does not do well in school. His mother describes Juan as very hyper. He doesn't like to go to bed at night and often puts up a fight. He does not play well with other children. He is impatient and often yells and fights with them. He doesn't listen when told to do his chores, and he can't seem to follow instructions given by the teacher. He is failing in school. He has been having these problems for some time. In your first session, Juan does not look you in the eyes when he talks to you. He participates in the different activities you ask him to. So this is an actual vignette that has been used in the oral exams previously. So what the goal is of this is for you to be able to look at this and find all the legal, ethical, critical crisis issues that are happening and then be able to treat it. So we're going to completely ignore that first paragraph there because that is all about legal and ethical issues. We'll go over that in a few weeks, but you'll see more of that. That second paragraph is really showing kind of the family makeup, right? What this structure looks like. And in this, you should be asking some questions because when we're considering the case conceptualization, we're considering everything about little Juan in this paragraph. So questions I'm having that might help with a diagnosis are, Linda is an active volunteer and a housewife. How active is that? Is that 8 hours a week, 8 hours a day? So is this kind of like another job? Or is one kind of, in and out of daycare, nannies, babysitters, whatever, and they're actually not giving him any attention? Jorge works. He's gone 3 to 4 days a week traveling. So he's going to be gone most of the day if he's flying around. But he does know his son does not do well in school, so he does know something about one. So it's not that he's, some students have thought like, oh, Jorge is probably a deadbeat dad. He's not around a lot. He doesn't pay attention. But he knows he's not doing well in school, so we know that he's there and he's caring about him in some way. But if he's gone 3 to 4 days a week and Linda is busy, who's watching Juan throughout this? So that's a question that I'm having that we're going to go over for crises, and we're going to go over that in another week. But that's a question I have about neglect as well as possible traumas. So now we go into more symptomology. In this third paragraph, Juan is very hyper, which is going to alert us to ADHD, right? Whenever we hear that, possibly anxiety, possibly ODD, oppositional defiance, possibly autism. So in that little, 6-word, 7-word sentence, we're getting a few diagnoses formulating. He doesn't like to go to bed at night and often puts up a fight. And I really do recommend you reading your vignette sentence by sentence and saying, okay, what can I get from this? So he doesn't like going to bed at night and often puts up a fight. Again, I'm getting anxiety. I am getting trauma. So was this kid sexually assaulted or abused or scared? I have a client now who he had a babysitter who used to lock him in the closet and then open the door and wear scary masks. And now he is terrified of closets. I have another client who was molested repeatedly for years whenever he was in the bathroom, and now as an adult has never gone on a toilet since. He will defecate in the corner of a room and won't use a toilet. So kids don't go to bed at night because they're awake, because they're anxious, because they're scared, because they're little stinkers who aren't going to listen. So, and probably way more things, but we're starting there. He doesn't play well with other kids. Is that because he is bossy? Is that because he has autism spectrum disorder and he doesn't play well because he doesn't get the rules of the game and it has to be his rules? He's impatient, yells and fights with them. Again, I'm thinking something neurodevelopmental. He doesn't listen when told to do chores, and he can't seem to follow instructions by the teacher. So again, I'm kind of falling to one of the neurodevelopmental disorders, possibly anxiety as well, right? Because he doesn't listen. That's probably coming from his mom, and is that he doesn't listen or he doesn't follow through. He can't seem to follow through reads differently to me than he refuses to follow through. And it's a small little nuance in the language, but to me, I'm not hearing ODD. I'm not hearing oppositional defiance disorder, or any of those DIC disorders, the disruptive impulse control disorders in this sentence. He's failing in school and he's been having these problems for some time. So failing in school, again, could be one of those anxiety or mood disorders. Could be that this fella has ADHD and he can't seem to focus. So he's disruptive and, he's just not doing what he needs to do and not doing well in class. And having these problems for some time generally means that this is a longer onset. This has been going on for a bit. So we're not looking at instantly, we're ruling out an acute stress disorder. We're looking at probably more developmental issues. So I'm kind of falling on to that. In your first session, Juan does not look you in the eyes when he talks to you. Okay, so instantly I'm triggered to trauma, abuse. I'm also, which we're going to talk about down the road, looking at culture. So why isn't Juan looking me in the eyes? Could have many, many, many answers. It could be respect. It could be trauma. He could be having a rough day. He could have limited pro-social skills. So like in the autism spectrum disorder where they don't make eye contact. but he participates in different activities you ask him to. So that final sentence is instantly going to be ruling out much of ODD for me, right? Because this is our first session and this kid's fine to listen to what I'm saying. And I know ODD has different settings, but he'll participate. So he can't seem to follow through, again, different than he won't follow through, and then he's participating with me. So I'm going to be completely ruling out ODD and probably leaning more toward ADHD or autism spectrum disorder. And so I'm going to make the choice to say ADHD, and that's what we're going with. There might be some other like Z codes that I give, but that's what I'm at right now. And that's kind of how it's done. You will not be making things up, so you don't need to. I did this with another student who won um, in order to make the sentence, he doesn't like to go to bed at night and often puts up a fight. When diagnosing Juan, he said, Juan told me that someone was under his bed and he was scared. And you're not making things up in this. You're really going by what you're given. So many of you, if you're lucky, will have some kind of intake form before you see a client, which is lovely. At my practicum site, someone did the intake that was very extensive. It was like an 8 to 12 page intake with a client. And then I reviewed that before I saw the client. So I kind of knew what I was getting myself into. But then I've had many other jobs where I didn't even know I had a 4 o'clock, and here you are sitting on my couch, and who are you? So this is a good amount of information to get before a first session. And yes, if you're working for a Medi-Cal agency in particular, you will have to diagnose off of a first session. So it is pretty common to have to diagnose off of this much information that you have with a kid, where you can play some games with them and all you really have are background from the parents. So that's kind of where we're going to go, where we're going to start now. If I were to type, whoops, I went backwards. If I were to type this up and turn this in, I would be doing just a little bit of regurgitating and saying, Juan is a 10-year-old kid, possibly, most likely of Hispanic descent based on where dad works and the names of the families. I'm just going to kind of assume for the purposes of this vignette that I'm working with a 10-year-old Hispanic boy. Also going to guess that if mom is a housewife and a volunteer, she's not working. And dad works 3 to 4 days a week, and he's a pilot. So I know that pilots can make decent money. So I'm going to say probably middle-class status. And then I'm going to go and say Juan is described by mom as very hyper, has difficulties going to bed and fights before going to bed, doesn't play well with kids, probably doesn't have many friends, doesn't listen when told to do chores. So it's going to be a little bit of regurgitating. And then due to this, I'm diagnosing one with ADHD. And I might either list the criteria that he meets. If he doesn't meet all of the criteria for ADHD based on this, I do kind of that ADHD unspecified, or like disruptive, impulsive, or neurodevelopmental unspecified. And that's okay too. And then from there, next week we'll go into the next kind of stuff that we're going to do, where we're going to look at the crisis, and then we'll start planning the theories and all of that. So I hope this was helpful. I'm going to post a whole bunch so that you can see what this looks like, including the setup of this, what the outline is of this. If you have questions, I have the what's that called? I have the discussion board open, the virtual classroom, or save them for our next class when we meet in person so that we can have those answered. Okay. Only last thing was that a few people were a little bit confused about how to log into the library. So if you haven't turned in the video on the library movie, the Oaklander video, your password should be your 6-digit birthday. So like 0101, 81. and your student ID number. So not your dnevin@jfku.edu, but your 8 or 9 digit student ID number will be your login. I do not have access. I can't tell you what your student ID is. If you don't know what it is, you should have that. But if you are having difficulty watching the Oaklander video, contact the help desk so that they can help you figure that out, because I don't have any back end IT skills in this that I can help with over here. So that's all I have for today. I think we will see each other. Let's see. We're going to see each other in a bit. We will see each other in a few weeks, in 3 weeks on the 4th of November. All right, guys. See you then. Bye.